Okay, good afternoon, good evening, everyone. Thank you for joining the second Fungal Frontiers in the Asia Pacific webinar. This series of webinars is a collaboration between the Asia Fungal Working Group and the mycosis study group of the Australasian Society of ID. And we wanted to hold such webinars because we wanted to have mycology teaching that occurred at a time that was friendly to those of us in this time zone. So I suppose we'll never be able to please everybody. Some people are still finishing their clinics, I'd imagine, and some people are on the drive home. But let's start. We have an interesting patient to discuss today. So I'm Hock from the Singapore General Hospital, and my co-chair is Dr. Sharon Chen, who is from Westmead Hospital in Australia. Yes, Sharon, please.
Yep. So thanks, Hock, and good evening, everyone. So I have the pleasure of introducing the speakers and the expert panels for tonight's session. And we are indebted to Dr. Cherie Gan for firstly presenting the case to whet our appetite for the expert panel discussion, represented by Professor Tan, Professor Chayakulkeeree, and Professor Slavin from Singapore, Thailand, and from Australia, respectively. The lit review has been ably carried out by 4 colleagues, Dr. Thuan Tong, Dr. Lee, Dr. Chen, and Dr. Chung. And we're looking forward to what they have to say. So without further ado, there will be a case presentation followed by interjections with some discussion and a literature review at each section, followed by a Q&A for about 10 minutes or so. So with just some housekeeping details about the Q&A, so we can see the screen here. And if you click on the bottom here in the Q&A button, this screen will pop up here. Type your question in the Q&A box and click send. Thanks, Jane. And at the end, there will be a request to fill in the questionnaire that will be popped up automatically on your internet browser when the webinar ends, and we thank you for that. So, Dr. Gan, take it away.
Yes, Cherie, why don't you start?
Hello everyone, I'm Cherie Gan from SGH. I'll be presenting the case today. So the case today is quite a long one. We will be dividing it into 3 parts. The first part starts with our patient, a 54-year-old Chinese lady with no past medical history or long-term medications. She presented to us in July of 2022 and was newly diagnosed with Philadelphia positive B-cell acute lymphoblastic leukemia. She was given her first cycle of chemotherapy with rituximab, cyclophosphamide, vincristine, dexamethasone, and doxorubicin. She was also given dasatinib, which is a BCR-ABL inhibitor. At this time, her white cell count was 193,000, and the ANC was 1.93. On day 11 of admission, she developed neutropenic fever and developed multiple new skin lesions over her face, trunk, and limbs, upper and lower. You can see on the photo here the multiple erythematous papules over her limbs, and these were also present over her trunk and face. Her blood cultures were drawn at the time and grew Candida tropicalis. She received anidulafungin from the 10th of August when we knew about the blastoconidia in the blood. Her chemotherapy was suspended, and she was also sent to see eye and also had an echo done, and there was no eye involvement, and there were no vegetations on her echo. Her PICC line, believed to be a possible source, was removed. However, she did have persistent candidemia also on the 12th and the 14th of August. We tested the sensitivities for the Candida tropicalis and determined that it was sensitive to Anidula fungin with an MIC of 0.12 as shown here. However, she continued to have persistent fevers, and she was sent for a CTTAP by the primary team, showing mild ground glass opacities and some tree and bud nodularities in the lungs, but otherwise the rest of the abdomen and pelvis and chest were clear. She underwent a biopsy of her left arm papule on the 17th of August, and the culture from the biopsy grew Candida tropicalis, the same one as the blood. A histology specimen shared kindly by Dr. Thuan Tong Tan from our pathology department shown here showed fungal yeast forms in the dermis and vessel, suggestive of invasive fungal infection. You can see on the PAS stain on the lower photo, the yeast forms in the histology specimen. There was otherwise no granuloma, vasculitis, or any malignant cells in the pathology slides, in the biopsy. This is just to show you her fever curve to appreciate the persistent fevers. Shown in red was the duration of candidemia. She was candidemic for about a week from the 8th to the 14th of August. Her line was quite promptly removed, and she was also on Anidula fungin the moment we knew about some yeast in the blood culture. These are her corresponding labs. I will just highlight here, and you can see in red that she had a return of her white cell count and neutrophils on the 22nd of August. And also on the 24th of August, you will see that there was a rising ALP as highlighted here. These are her persistent fevers.
So we have a patient with positive blood cultures. We know what the bug is. We know the MIC, the sensitivities. We've got the right drug, and her white cell count has returned. Why should she be persistently febrile? So maybe members of the expert panel could chime in and help us along.
Well, I might start. I think we're very concerned with chronic candidiasis, invasive or disseminated candidiasis here, potentially with intra-abdominal involvement. And this will often take a very long time for the fever to resolve. I guess the other points are, have any foreign material been removed? Have we got source control? Have we got another focus of this infection? But I'd definitely be worried that it has disseminated this Candida infection.
Thanks, Monica. Would Methee or Thuan Tong like to offer some views?
Yes, Thuan Tong here. We are giving the Anidula fungin. There are sites where it doesn't enter very well, it doesn't penetrate very well. So that can be a concern. The other thing is the bioburden. We had a biopsy which the fungus, the yeast, was overshot with hardly any immune response around it. So it may be far more pervasive, as Monica says, chronic disseminated, or perhaps still acute part of the disseminated candidiasis is still at play. Over.
Thank you. Thank you.
Yeah. Yes, I agree that this case, you should think about the complication of candidemia, disseminated or systemic candidiasis. If you look at the complete or full blood count, you will see that once the neutrophil recover, you will see the rise of the alkali phosphatase that indicating that probably something in the liver, such as abscess. And also other complication is possible as well, like endocarditis or eyes involvement, even though the patient was already checked up with the echocardiogram on the eye, but it's really early. So the complication is normally not occur during the first week of the candidemia, but it can occur later. So this is the second week. Once the neutrophil start to increase, that it can be some complication as well. So besides the candidiasis, it could be something other organism as well. The procalcitonin increase. The procalcitonin is 10, right? So it's possible that the patient may have other infections, such as bacterial infection. That's something that we should think of. The cause of consistent fever in this case as well as other fungus like aspergillosis, there's other organism that is still we need to think about that as well.
Okay, good. So I think hepatosplenic candidiasis or chronic disseminated candidiasis is certainly a good thought. Infection in a site that acidular fungin doesn't penetrate is another consideration, and of course we've got to worry about a second pathogen. Okay.
Okay, thank you very much for sharing your thoughts. These were some of our concerns as well. So the team actually, we repeated the CTTAP, looking for other any focus on infection that was not addressed. We did find multiple new rim-enhancing subcutaneous collections, predominantly on the back. I've highlighted one of the larger lesions here with the light blue arrow. She also had multiple new hypodensities in both kidneys. Her liver and spleen, the cuts I didn't show here to avoid cluttering the photo, were actually normal on the CTAP. She also had an MRCP done because of concerns for hepatosplenic candidiasis, which did not show any hepatosplenic lesions. The CT chest was also done in the same setting and showed you'll appreciate multiple new increase in the nodularities, patchy ground glass changes, and consolidation in both lungs. So here's where we are at now on a timeline. On the 22nd of August, she had a return of white cell count as mentioned. And you will see that progressively over the next 1 to 2 weeks, she developed multiple new abscesses all over her body, especially seen on the limbs. And it was so obvious that it could be seen from the end of the bed. You can see all these multiple lumpy lesions on her forearm, the dorsum of the hand, and some of them were quite necrotic looking. And I think as Dr. Cheyakulkeeree mentioned earlier, there is also concern whether there's any other fungal pathogen beyond just the candida, especially given these necrotic skin lesions. So she underwent incision and drainage of all of these lesions by our surgical team. All the cultures from the drainages of all these abscesses came back as growing the same bug, Candida tropicalis, and it was negative for other microorganisms, including mycobacteria, bacteria, and nocardia cultures. The histology just showed necroinflammatory exudate. So just to recap where we're at now, we have a lady with newly diagnosed Philadelphia positive BALL who's just received her first cycle of chemotherapy. She has a disseminated candidiasis with a Candida tropicalis sensitive to azoles, echinocandins, involving the blood, multiple skin nodules, and subcutaneous abscesses, kidneys, and possibly also the lungs. She was candidemic for quite long, for about a week, from the 8th to the 14th of August. Her echo and her eye screens were repeated after the recovery of her counts, and again, there was no endocarditis or any eye involvement. She has been on anidular fungin, which is culture-directed, since the 10th of August to currently. She did have some rising bilirubin and ALP, but we were not able to find any hepatosplenic lesions on her abdominal imaging. Her CRP actually improved from 452 to 103 by the end of September 2022, and anidular fungin was switched to oral fluconazole to facilitate discharge. She was discharged well on the 7th of October, and her dasatinib was resumed but switched to ponatinib due to suboptimal BCR-ABL response by the hematologist.
Okay, so at this point, we would like to invite Dr. Pakpoom to present his view of chronic disseminated candidiasis. Thank you.
Thank you. So I would like to give you a short review on the chronic disseminated candidiasis. So if we look into the data on epidemiology and risk factor, the incidence was around 3 to 29%. We mostly see the patient with the chronic disseminated candidiasis or CDC in hematologic malignancy patients who are receiving induction or salvage chemotherapy. And actually the incidence was highest in acute leukemia patients. But actually many papers report slightly higher incidence in acute lymphoblastic leukemia when compared to acute myeloid leukemia. The risk factors include the patient with a younger age who have prolonged neutropenia more than 14 days, and the patients who receive the prophylactic fluoroquinolone for antibacterial prophylaxis. So actually the pathogenesis of the chronic disseminated candidiasis is unclear. But if you can't give some hypothesis that you have the candida colonized in the gastrointestinal tract, and then the patient receives induction chemotherapy, and that is mucosal injury from the chemotherapy. So that's translocation of the candida from the gastrointestinal tract into the portal system. So the important thing is that when the patient have the neutropenia, they cannot get rid of the candida from the portal system, and then the candida go to the portal venous circulation. If you look into the figure on the left, you will see that the portal venous circulation gives the supply to the liver, to the spleen, and to the kidney. So the candida can go through multiple visceral organs, especially the liver and then the spleen. And also sometimes it can go to the systemic circulation and go to other visceral organs such as lung, even the skin, or even the muscle. And if the patient have the recovery of the absolute neutrophil count, there will be some imbalance of the immune system. The patient may have some immune system that shift toward T helper 1 and T helper 17, more than T helper 2 or regular T cell, and it causes more pronounced inflammation. So if you have the candida that go to the liver, to the spleen, you will have the more inflammation of the liver, inflammation of the spleen. So you have the manifestation of the hepatosplenic candidiasis. So the most common presentation is the persisting fever after the ANC recovery. Actually, the patient may have the fever before the ANC recovery, and then the fever persists after that, or even the fever may occur just after the ANC recovery. So we find the patient with a persistent fever in approximate around 85 to 100%. And about half of them had right upper quadrant abdominal pain. And about half of them also had hepatosplenomegaly. Interestingly, that about 40% of the patients also have respiratory symptoms such as productive cough or some degree of dyspnea on exertion. I tried to go to the multiple case series that reported in the literature, and actually the largest case series was reported like about 60 patients. So I give you some example of the 6 case series that report between 1995 to 2012. You can see that the most common organ involvement was liver, around 87 to 95%, following by spleen and kidney. But if you see the column on the right, you see that around 3 series report that about 20 to 60% of the patient also had lung involvement in the chronic disseminated candidiasis. It can be either pulmonary nodules or some cloud-glass opacity. For the diagnosis, usually that we diagnose by the clinical diagnosis plus the radiology, because the microbiological diagnosis of the CDC is quite difficult. The hemoculture demonstrates low sensitivity, around 20%. Some may say that because the candida is limited to the portal system, so it's difficult to obtain the candida from the systemic circulation. And also the other reason is like a tissue phase of the candida, when you have only the candida and the inflammation of the body, so you may not get any yield from the culture. The beta-glucan also demonstrate about the 55%, but I think that it depends on the pathogenesis of the candida. If you have the candida from the portal system that go to the liver and spleen correctly, the yield of beta-glucan is quite low. But if like a persisting candidemia from the acute candidiasis, the beta-glucan sensitivity is slightly higher. So actually the gold standard is to perform the tissue biopsy and to see the histopathology of the candida involvement. But unfortunately, even the direct examination and tissue culture show low sensitivity. And you know that the patient may have some limitations such as the thrombocytopenia, so the procedure may be difficult to perform. So the best thing is to perform the radiological diagnosis by performing the arterial enhancement, the CT abdomen. So the CT triple phase of the liver and also the MRI of the liver show good sensitivity. PET scan show no additional benefit on the diagnosis. The typical finding on the CT abdomen, you will see multiple abscess in the liver and the spleen, and the abscess are varying in size. If you look into the right picture, if you perform arterial phase CT, you may see very classic sign of the hepatosplenic candidiasis by show hyperattenuating rim surrounding hypoattenuating center, so-called bull's eye lesion. But this is not very common to see in all cases of CDC. So regarding management of the CDC, currently there is no high-quality study to guide any antifungal option. But I would like to show you some guidelines that describe the management of the candidiasis, that you should treat the patient with either liposomal amphotericin B for echinocandins for several weeks, followed by fluconazole 400 mg once daily for several months. If the patient have received any consolidation chemotherapy or salvage chemotherapy, again, we should not delay chemotherapy. Actually, there were some case series that reported even the patient received further chemotherapy, the success rate of treatment still more than 80 to 90%. So we should not delay the chemotherapy. You may give the NSAID or corticosteroids in the patient who have the persistent fever. So actually, there is some debate about that should we give the liposomal amphotericin B or high-dose echinocandins. We cannot have the summary yet, but I show you a very small study, including 20 patients with the chronic disseminated candidiasis. It was retrospective study comparing high-dose liposomal amphotericin B at dosage of 5 mg/kg compared with the high-dose echinocandin. And as you can see from the Kaplan-Meier curve on the right-hand side, that the patient who received the high-dose liposomal amphotericin B tend to survive more than the patient who received the echinocandin. But I think it's difficult to make the conclusion by only small single study that may have some confounding factor. Regarding treatment response and the prognosis, usually the fever subsides within 2 to 4 weeks after treatment, and sometimes a bit longer. If you would like to perform the radiology to see the response of the treatment, you should repeat imaging every 2 to 3 months. Actually, that is very slow radiological response. Sometimes it may take about 3 to 6 months to see any response. The mortality rate is not quite high, around 17 to 36%, and it depends on the hematologic disorder more than the infection itself. If you have the no hematological remission at the time of CDC diagnosis, or the patient have prolonged neutropenia more than 1 month, it will increase the mortality rate. So my last slide is to compare the acute and chronic disseminated candidiasis. The patient with the CDC usually present at the episode of neutrophil recovery, usually have the negative blood culture, but positive radiological imaging for the multiple hepatosplenic abscess or kidney abscess or even lung lesions. The cause of this disease is quite like a subacute to chronic. The pathology show the granuloma formation. The sites of involvement are predominantly liver, spleen, and also the kidney. And treatment response is better than acute disseminated candidiasis. So this is my review on the chronic disseminated candidiasis. Thank you.
Thank you, Dr. Papoon, and we will now revert to Dr. Gan to continue with her case history, if I've got it correct.
Thank you, Dr. Papoon. So we go back now to our case. This is just part 2 of the case. We promised a long case, so we will continue. So she continued to have persistent fevers at home, ranging up to 38.5 degrees Celsius. She developed some new spots over her right flank and bilateral forearms after discharge, and had a slight rise in her CRP to 133. She also had a worsening liver function, with ALP and GGT rising to about 6-7 times the upper limit normal, and AST-ALT about 3 times upper limit normal. She was brought in on the 29th of October, about day 77 of her antifungal therapy for these reasons. Her blood culture was repeated on admission and was negative. Fluconazole was switched to anidulafungin due to concerns of fluconazole-related liver injury, and biopsy was arranged for the new forearm lesion.
Thank you, Dr. Gan. So we will now go to the second literature review on the pathologic features of disseminated candidiasis, presented by Dr. Lee Yihan. Thank you, Dr. Lee.
Yes, so could you show? Yes.
Yep.
So the pathologic features for the disseminated candidiasis, I think the mainly inflammatory pattern one is depend on the level where the organism is infiltrated, and on the other hand, it's also depend on the immunostate of the patient. So like here in the first pictures on the left side, this is the very first biopsy of the patient when the WBC is quite low. So this biopsy actually is quite quiet skin biopsy. The epidermis almost unremarkable. There are only in the upper picture you can see a micro abscess composed of neutrophils and some debris in the superficial dermis, and it's very focal. So only by the help of the special stain, which means GMS, PAS, we identifying the yeast form organism. And then you can see is that there is sort of like lumen around it, which is it is a vessel. So when we identify the fungal organism in the vessel, it may be infiltrate into the vessel wall or forming a thrombosis of the vessel. We can call it angio-invasive. But by morphology on histo, we can only the most differentials most often is Candida, aspergillosis, and muco. But in this specimen, we don't see any like hyphae to suggest like aspergillosis or muco. But of course, we need. The morphology is not the diagnostic features for the species of the fungal organism. We need to account for the. We need to depend on the microbiology culture. So in the later one, the second biopsy in the middle and right side, it is show a totally different pictures. You can see there is a quite large necrotizing granuloma in the deep dermis. Again, the epidermis looks unremarkable, generally unremarkable. So the granuloma, which is very huge and with a large central area of necrosis. This is a typical features for infectious granuloma. And there are some by the PAS stain, GMS stains on the right side, you can see the yeast form and very occasional hyphae of the fungal organisms. So I think in the second specimen, it reveals the chronicity of the disease and also reveals the immuno response of the patient, which is much better than the first one compared to the first biopsy, which is, I think, is also correlate with the immunocompetency of the patient.
Thank you, Dr. Lee.
Thank you, Dr. Lee. Do we go back to the case?
Yep.
Thanks, Dr. Gan.
I'll take it away from here. So she was kept on anidulafungin via outpatient antibiotic and was actually well enough to be managed as an outpatient. There was a steady downtrend of a CRP as shown in the graph here while she was on antifungal therapy. She actually managed to reach a CRP of 53 on the 29th of November. She did, however, continue to spike intermittent fevers with occasional developments of 1 to 2 new skin lesions in new areas while the old ones healed.
So we have this patient with very persistent symptoms. The white cell count has gotten better. The CRP looks like it's better, and yet she still has new skin lesions popping up, and she continues to have some fever at home, despite what appears to be an appropriate antifungal. So because we all know that we are dealing with a case of chronic disseminated candidiasis, and because there's a huge element of an immune response contributing to the pathology, I suppose the natural question is whether or not we should be using steroids at this stage. So may I pose this to the expert panel, please? Monica, maybe ladies first.
Thanks. Well, yes, I think I'd be seriously considering steroids. We have to weigh up the pros and cons of steroids. She has new lesions appearing. She still has ongoing fever. And there's always this debate about, can you resume chemotherapy in someone who's got ongoing fever, and a reluctance to do so. So the condition really can be treated by anti-inflammatories, and steroids would be the most common cause. We have to bear in mind that, if she still has active candida infection, as distinct from an iris type syndrome, we could be making it worse by giving her steroids. But I think probably we're very close to the time now where you would consider starting steroids. She's had a good course of antifungal therapy. So at this point, I'd be very tempted to start steroids. I may hold off a little longer, but I think that ultimately she's going to need some sort of anti-inflammatory to control this immune response.
Thank you.
Yep.
Go on, Methee.
Methee.
Yeah, I have to admit that I have never seen a candidiasis who has clinical manifestation like this, but I have seen at least one patient very similar type of this kind of manifestation in HIV patient who had disseminated tuberculosis. After treatment with anti-tuberculous drug and the CD4 count rise, and then the patient has multiple cutaneous abscess, the culture negative, and so he has iris. So the patient responded very well with the steroid. So in this case, I do agree that steroid would be probably one of the good choice, but I have to make sure that the patient receive the antifungal drug long enough to get rid of all of the viable candida in the body. Otherwise, the patient may have a relapse. One thing that may worry me is that echinocandin is the main drug in this patient, and echinocandin, we know that the penetration of this antifungal agent is not that really good in some organ, that it could not kill the candida in some the sanctuary phase of the organism, that it could cause a relapse later on as well. So this thing that we have to make sure.
My take is I'm a bit worried, mainly because the fever is very fierce, and as what the concern about insights where perhaps the penetrance of an angular fungin is not good. I think what we have not seen, or I may have missed it, is how is the disease under control? Did we achieve good remission with the prior cycles, or is there an element of the disease coming back? And certainly before steroids, I'll be concerned about if there's residual disease, and I think more repeated imaging and sampling might be warranted. Over.
Yes, thank you. A very thorny and knotty topic. Perhaps we can then go back to the case and see how it progressed, or what the managing physicians did. Cherie, please.
Yeah, thank you. So this is where we are at now. I've plotted her antifungals in the bottom in blue, so that you can see what she's received so far. At this point, she was on anidulafungin and then was switched to fluconazole in the end of November, because she citing fatigue with a daily commute to our outpatient antibiotic clinic for IV anidulafungin. On the 29th of November, the hematologists on their own actually decided to start prednisolone at a dose of 30 milligrams once a day, because of their concerns that this could be like an inflammatory immune-mediated issue. After they started steroids, 1 week in, her fevers actually lised, and the CRP continued to improve from a prior of 53 to 18. Her LFTs then went up further to 5 times of upper limit normal, and her fluconazole was ceased on the 8th of December. She received prednisolone at a tapering of 10 milligrams per week, and total she received was about 3 to 4 weeks in duration. In January 2023, her skin lesions continued to improve while she was off both antifungals as well as the steroids. And I think Dr. Tan did ask earlier about her disease status, and at this point, I think she was there was no concern of any relapse of her leukemia.
Okay, so we now come to the third section of the Lit Review, which will be presented by Dr. Benjamin Cheng from the Singapore General Hospital, and he's going to speak to us about using steroids in chronic disseminated candidiasis. Thank you, Dr. Cheng.
Thank you. So, IRIS has been well recognized in fungal infections, and we look out for respiratory deterioration during the effective treatment of pneumocystis, URFGI, pneumonia, and AIDS. We delay antiretroviral therapy initiation in crypt meningitis and HIV because of it. So chronic disseminated candidiasis, or CDC, similarly is a clinical entity within the spectrum of IRIS. And there are typically two clinical phases that are described in CDC. Firstly, the aplastic phase, during which the patient is neutropenic, that is dissemination of candida, usually as a result of chemotherapy-induced mucositis of the gut. And this then is followed by the next phase, which is the inflammatory phase during recovery from neutropenia, where the patient then develops symptoms from the inflammatory process that affects the site of the earlier dissemination. So typically there is fever, there is potentially hepatosplenomegaly, abdominal pain, as well as the well-recognized increase in liver enzymes. So the pathophysiology underlying these manifestations may be simplistically understood as an imbalance between the pro-inflammatory Th1 IL-17 response versus the anti-inflammatory effects of Th2 and Tregs, as what was earlier indicated by Dr. Pakpu. So this leads to an increased pro-inflammatory cytokines, especially interferon gamma, TNF-alpha, which then activates M1 macrophages and results in the granulomatous inflammation that we see on histology. Now, these granulomas can then in turn produce more interferon gamma, which provides a positive feedback loop. Now, but if we look at this inflammatory cascade more specifically in the context of CDC, this small study compares 44 CDC cases versus controls. And what was found was that patients with CDC have higher levels of IL-6, IL-10, soluble CD25, IL-1 beta, and TNF-alpha, with a concomitant decrease in IL-2. There's also an increase in the T cell expansion of candida-specific interferon gamma positive T cells. However, it's notable that the candida-specific IL-17 positive T cells were not more compared to the controls. And this suggests that actually the IL-17 mucosal immunity pathways are playing a minimal role, if at all, in the inflammatory phase of chronic disseminated candidiasis. Now, how then can steroids come into the picture? So this diagram helps us to revise again how anti-inflammatory effects of steroids are mediated. So now in the absence of glucocorticoids, the glucocorticoid receptor is held in the cytoplasm by chaperone proteins. And when we introduce steroids or glucocorticoids, this will bind with the glucocorticoid receptor and remove it from or dissociate itself from the chaperone proteins. And this will then translocate into the nucleus, and the anti-inflammatory effects are mediated majority through regulation of gene expression. And the mechanisms of gene expression, gene regulation, will include things such as transactivation or direct and indirect repression, as well as inducing mRNA decay of certain genes, such as those that mediate TNF and CCL2. Now, the effects of glucocorticoids on T cells and cytokines are not necessarily uniform. So in this table, you can see that the Th1 cells are particularly sensitive to glucocorticoids, whereas that is not necessarily so for Th17. You can see also that glucocorticoids very much suppress interferon gamma as well. So all this eventually is believed to allow steroids to right the pro-inflammatory balance and swing it towards an anti-inflammatory effect. And perhaps this is much more mediated by its effect of repressing the Th1 pathway and less so of the Th17. Now we can see this demonstrated in the earlier paper presented, where actually when they ran the test, they found that the interferon gamma positive candidate-specific T cell response is shown to be significantly suppressed in steroid-treated CDC patients versus patients with chronic disseminated candidiasis, but without steroid exposure. Now, in clinical practice, we can draw a similar picture in the use of steroids for chronic granulomatous disease. So CGD results from a defective phagocyte killing due to defective NADPH oxidase, and the end result is early and recurrent bacterial infections. There is also very exuberant and excessive inflammation that is characterized by chronic granulomatous inflammation, so exuberant that it can result in obstructive symptoms in the GI or even the genitourinary tract. And in these cases, we see that treatment with steroids have been important in managing the complications caused by the. Thus, there have been various descriptions in the literature of the use of steroids for the management of chronic disseminated candidiasis. Now, these tend to be either retrospective small case series or single case reports, both in the adult as well as the pediatric populations with hematological malignancies. Now, the overall theme is generally familiar. Most cases will give steroids in the range of 1 to 2 milligrams per kilogram. Most cases describe a long time interval between the onset of symptoms that are associated with CDC and the initiation of steroids. And this is likely a reflection of the time taken to exclude other diagnoses before steroids are actually started. But once started, the resolution of fever and the associated symptoms are typically fast, described in a matter of days. The duration of treatment is very much variable, but it's typically long, and it will be quantified in weeks to months. This is the continuation of the similar table, just showing mainly the pediatric patients, but the general theme is also still similar. Now, allowing for some publication bias, most cases describe themselves as success stories. There's no recurrence of the fungal infections. It allows for the continuation of treatment of the underlying hematological malignancy, such as the continuation of chemotherapy or even eventual transition to stem cell transplant. There is symptomatic relief, which reassures both the patient and the physicians. And some may also postulate that steroids may disrupt the granulomatous inflammation. And with this, that may even allow for better antifungal penetration and thus more effective treatment of the disseminated candidiasis. However, on the other end, it is also still very important to always consider the potential adverse effects of steroids, their potential infective as well as metabolic complications that we are so familiar with. It is also important to consider that the pro-inflammatory state also has or also contributes to an anti-leukemic effect. And if we over-suppress this response, it may lead to a risk of hematological relapse. So therefore, could there be other alternatives or steroid sparers perhaps? So anti-TNF alpha agents such as infliximab and adalimumab are an interesting choice, perhaps more so the targeted adalimumab compared to infliximab. Thalidomide has known immunomodulatory effects. It has negative effects on TNF alpha synthesis. The steroid sparing, it has been used as a steroid sparing agent in steroid-dependent IRIS, for example, in managing TB paradoxical reaction. Now, for NSAIDs, NSAIDs are typically used for milder manifestations. It can also be used as an adjunct if steroids are not giving a desired effect. However, its potential nephrotoxicity is a limiting factor. Statins is an interesting proposition. It has potential antifungal properties because the fungal HMG-CoA reductase shares homology with a human enzyme, and therefore statins can potentially inhibit the synthesis of cholesterol. we also know that statins have potential anti-inflammatory properties, especially over, I think, over the Th1 pathway. However, it has to be said that potential drug-drug interactions between statins and triazoles that are typically used to treat CDC would be a major obstacle. Now, if we take a few steps back, can we see if we can predict who may actually get severe manifestations of chronic disseminated candidiasis and therefore be considered for earlier steroid therapy? So in this prospective match control of 38 cases, which uses a candidate gene approach, the gene in the IL-1 beta C allele carriers were actually found to have more than 2.43 increased odds ratio for development of symptomatic chronic disseminated candidiasis. There were also a few other single nucleotide polymorphisms that trended towards significance. And similar to the previous study, there were no associations found in associated IL-17 gene polymorphisms, again reflecting the minimal role of the IL-17 pathway in the inflammatory phase of CDC. So at this point, we can actually conclude that CDC is certainly in the spectrum of fungal iris, and this would argue for its role of using immunomodulators such as steroids in cases where the response is too overwhelming and detrimental. We find clinical parallels with other fungal irises. We also see steroids being used in cases of chronic granulomatous disease. Now, CDC case descriptions are, as we saw in the previous tables, are very small in number, but they do corroborate each other's findings and report beneficial effects overall. Now, because these are all immunocompromised hosts, the manifestations of CDC has to be a diagnosis of exclusion at the end of the day. So overall, there is certainly a role for steroids. But these simple conclusions have to generate even more questions. So firstly, as a type of iris, what actually are the real drivers of iris in CDC, right? Is it any particular cytokine such as interferon gamma? And in going further into that, then what is the cytokine profile that identifies with CDC? Is there a unique cytokine fingerprint, so to speak? Right? And going even a few steps behind, are there genetic polymorphisms that will identify patients with predisposition to patients who will develop very much make chronic disseminated candidiasis? And because knowing these things would then allow us to actually make this less of a diagnosis of exclusion. And finally, although we know that it's a place for steroids, it is important still to get the balance right. So when is the trigger point to start steroids? How long should we give it for? And are all steroids the same, or is there one that's better than another? And are there any other effective agents other than steroids that we could actually consider? And certainly all these questions are all interrelated. And to find the answers, I think we will likely still have to go back to fully understand the immunology behind chronic disseminated candidiasis. And with this, I'll pass the time back to Sharon. Thanks.
Thank you, Dr. Cheng. So we have good evidence that steroids do work, and we're well on the road, maybe, to personalized medicine to look after these patients that we see. Okay, so back to Dr. Gan then to continue the story, part 3.
Thanks, Prof. So we are into the third and final part of our story now. It continues in 2023 this year. So just to recap, she had a disseminated candidiasis for quite a few months. In the end of 2022, she completed 19 weeks of antifungals to the 8th of December. She also received a course of prednisolone of about nearly 4 weeks. During the 30th of September, her dasatinib was switched to ponatinib at that time due to some suboptimal BCR-ABL response with subsequent improvement after the switch to ponatinib. She was given vincristine and prednisolone sort of as a bridging because she was eventually planned for transplant and they were waiting for blinatumomab to arrive. She was then started on blinatumomab as a bridge to transplant and received her first dose on the 30th of January 2023. The very next day, she developed fever 38.3, and the ID team was called to see her. On further probing, when we took her history, she did mention that she had some increasing frequency of headaches since December 2022. One day later, she developed new word-finding difficulties and a deterioration in handwriting, but otherwise had a normal neurology examination. An MRI brain was done with contrast to work up this change in her handwriting and slight mentation changes. These are the T1 with contrast sequences. I will highlight here with some orange arrows, and you can see that she had some sub-centimeter rim enhancing lesions. There's quite a few of them in bilateral basal ganglia.
Okay, so a new twist in the case. We have a monoclonal antibody used, and then these CNS lesions happening very quickly after. So what could be the cause? May I again pose this to the expert panel?
I think we should do boys first this time.
Yeah. Yes, of course. Thuan Tong, would you like to start?
Yeah, I think after Blina, we can expect some form of cytokine release when the T cells are engaged. But I am surprised to see nodular kind of micro abscesses kind of lesions, which therefore brings me to the point of, did we adequately clear the candida? Especially we had quite a long stretch of anedular fungin, which doesn't reach the brain so well. We've had cases where fungal granuloma stays in the CSF for a long stretch of time. So I'm worried that it's the candida that we're dealing with. We may have some form of cytokine release, especially with all these word-finding difficulties, but I think that one is not so well characterized on the scan. The scan is showing more of a candida process. Over.
Methee, you want to say anything?
Yeah, the first thing that came up in my mind is that the lesion, the very tiny lesion in the brain, could explain the difficulty in handwriting in this patient. It seems like it's scattering all over the brain. That you have to see the lesion in the region of the brain that control the handwriting. That I'm not sure. That I'm not a neurologist, so that's the first thing. But what I'm trying to say is that those lesions could be inside the brain for quite a long time. But we did not perform the MRI. That's why I did not see the lesion. But it could be the iris of the candida, or it could be the relapse of the candidiasis. But it's I'm not sure because the lesion is not well characterized, like Dr. Tan said. So it could be either one of them. So I think we still need, if we cannot exclude, we need to treat them all over again with probably like liposomal amphotericin beta, which have the better CNS penetration and also continue the steroid. Yeah.
Monica?
Yes, I agree. I think this is too early really to be a complication of the blinatumomab, apart from a cytokine release. But to see these lesions in the brain, we have to think that they're probably related to the initial candida infection, although I would keep an open mind in that this patient has had a month or more of corticosteroids, so other opportunistic infections are possible. I think about TB. I think about bacterial infection. I think she's not quite so immunosuppressed to worry about toxoplasmosis. She's only had prednisolone and one course of chemotherapy. So I think those other things would be in the back of my mind, but I'd really be very suspicious of the candida. And as we heard from Prof. Thuan, the lack of penetration of the echinocandin might be playing a role here, and these may not have been adequately treated initially.
Okay, thank you very much to the three experts.
Okay, thank you for sharing your thoughts. So I will just show some of the workup that she underwent. So we went on to perform a lumbar puncture for her. The CSF white cell count was 36, predominantly lymphocytic. There were no blasts or any malignant cells in the CSF. Her CSF microbiological tests all came back negative, including fungal cultures. Serum as well as her CSF cryptococcal antigen as well as galactomannan was sent off, and both were negative. Urine was also sent for histoplasma antigen, which was negative. A serum 1,3-beta-D-glucan was sent and was high and positive at 215, and the reference range is normally less than 60. She was empirically covered with IV liposomal amphotericin B at a dose of 5 milligrams per kilogram per day. And by about 4 weeks later, gradually her headache improved, and her MRI done 4 weeks later showed that the lesions in the bilateral basal ganglia had decreased enhancement. So at this point, because all the microbiological tests came back, and there was improvement with the amphotericin B, we felt that most likely we presumed this to be a CNS involvement of a chronic disseminated candidiasis, as alluded to by the expert panel earlier.
Right. Thanks, Dr. Gan. So now we have the fourth segment of the LIT review, which is about CNS candidiasis, and I'd like to invite Dr. Jasmine Chung, also from the Department of Infectious Diseases at Singapore General Hospital. Thank you, Dr. Chung.
Thank you, Prof. Chen, and thanks for having me here. So I'm going to talk about disseminated candidiasis, and we know that the candida can come from the intestine, or it could be line-related. And specific to our patient, the sites of involvement were the brain. Next click, Sherry. Were the brain, the kidney, the lung, and there were disseminated cutaneous lesions. Next slide. Now, when we think about CNS involvement, typically we think about mold infections or CNS infections, and these are the frequency and incidence of CNS involvement. In cryptococcosis, depending on the degree of immunodeficiency, it can be as high as 82.2%, especially in the HIV patients. But for candidiasis, CNS candida infections can happen, but they're not that common. In disseminated candidiasis, it's about 6%. Candida brain abscesses are even rarer, and the associated mortality if CNS is involved, it can be as high as 90%. Next slide. If there is CNS candida, and usually the risk factors for these are related to neurosurgical procedures, which could be a contiguous process, or it could be due to risk factors for invasive candidiasis, in which case it's a disseminated process, and we see it in disseminated candidiasis. Local infections are for those who have undergone neurosurgical procedures. The findings on neuroradiology are typically non-specific. Sometimes we see multiple microabscesses, or there could be leptomeningitis seen. Sometimes there may be complications such as intracranial hemorrhage, subarachnoid hemorrhage, mycotic aneurysms, or there may be some vasculitic processes involved. On CT, these microabscesses are typically hard to appreciate, and sometimes there might be communicating hydrocephalus. But an MRI seen, what we normally find are microabscesses typically less than 3 millimeters in size. They can be multiple and are most commonly located at the gray-white matter junction in the basal ganglia and or the cerebellum. I'm just going to focus on the CSF analysis. For microabscesses, normally we have normal biochemistry. Can we go back one slide? Thanks. And CSF cultures are typically negative. For macroabscesses, there could be moderate pleocytosis with elevated protein, and CSF cultures may or may not be positive. Next slide. Next slide. So for hematogenous spread, we talked about things occurring at the gray-white matter junction. Next click. And let's look at the pathophysiology of these. So you have a candidemic process, there's candida in the blood, and then there's a blood-brain barrier. Next click. And when the blood-brain barrier is not well developed, this is typically what we see in neonates. There's an increase of CNS candidiasis. Patients without IE may also develop CNS candida infections. And typically this may occur in the immunocompromised host. Perhaps there's increased permeability of the blood-brain barrier. Next click. There could be paracellular or transcellular translocation of the candida. Next click. And if there is impaired T cell function, then candida brain abscesses could develop. Next slide. So what does the real-world data show us? So this was a series in France, and over a 13-year period, they collected only about 24 cases of probable or proven CNS candidiasis beyond neonates, which tells us that it's not very common, but there are some things to learn from this. Next click. Next click. So disseminated infection is likely to occur in patients with hematological malignancy or those with an infective endocarditis. Next slide, please. And if we look at these 24 patients, in those patients with disseminated candidiasis and hematological malignancy, microabscesses are actually not that uncommon. Next click. And the diagnosis of CNS candidiasis is typically delayed. And this is what we find here. So we can see either macro or micro abscesses, and they enhance on the T1 radar imaging, and there may sometimes be hemorrhagic conversion seen in slide D. Next slide. So candida brain abscesses are typically very difficult to diagnose. And then therein lies a question, is there a role for the beta-D-glucan? Beta-glucan, we know it's a non-specific biomarker. It can be found in different funguses, as shown in this little cartoon here. It can be found in Histoplasma, Fusarium, Candida aspergillus, and Pneumocystis. But there could be false positive results as well in patients who are on hemodialysis or IVIG, and even in patients receiving beta-lactam therapy, which is very common in our heme malignancy patients. Next slide. Then pressing this question further, is there a role to test for beta-D-glucan in the CSF analysis? Now, the ERTC guidelines have been revised from 2008 to 2020. In 2020, the revised guideline says that if there are two values of beta-D-glucan detected in consecutive serum samples, you can make a diagnosis of possible candidiasis. But is this criteria applicable to CSF beta-D-glucan? At least for now, it is not validated for use. Next click. In a patient with Candida albicans meningitis following a neurosurgical procedure, the authors from this paper actually tested CSF beta-D-glucan in his CSF samples, and lo and behold, it was elevated. But when they found this, they went on to test further other CSF samples that were available in the lab. And these were in patients who did not have Candida meningitis. And you can see from this dots here that even in patients without CNS candidiasis, there were false positive results present. Next click. So CSF beta-D-glucan has to be interpreted with caution. Next click. Now, as mentioned earlier by the various experts, there are gaps to the Candida treatment guidelines. In the IDSA guidelines for chronic disseminated candidiasis, the recommendation is for the use of ambisome 3 to 5 milligrams per kg daily or an echinocandin, but these doesn't cross the blood-brain barrier, and there are sanctuary sites like the eye and the brain that may happen, and Candida may hide in these areas. Next click. In contrast, for neonatal candidiasis, echinocandins are not recommended, and fluconazole is recommended instead. Next click. And so in selecting treatment for candida brain abscesses, we need to think about agents that would penetrate the brain well. And the properties for antifungal agents for treatment of CNS infections are those with high lipophilicity, low molecular weight, low protein binding, and it doesn't the drugs doesn't get pumped out of the cells. So the agents of choice are fluconazole, isavuconazole, voriconazole, amphotericin or liposomal amphotericin with flucidazine. And just to mention for isavuconazole, the newer agent, it penetrates the brain tissue, but it doesn't penetrate the CSF that well. Next slide. And so for disseminated candidiasis, some of the considerations that we have to think about is that disseminated candidiasis is not uncommon in hematology patients. As mentioned multiple times, candida can compartmentalize in brains in patients with high candida load, as illustrated by this patient, and who are on prolonged courses of echinocandin therapy. Now, whether we test the CSF or not, the data is not strong at this point in time to recommend routine lumbar puncture or brain imaging, unlike some of our practices with patients like aspergillus in the lung, brain imaging. We sometimes do it more routinely just to make sure that we have not missed a CNS lesion. So for a patient with high candida load, there must be some degree of clinical acumen to think about the possibility of candida hiding in the brain. We need to watch for subtle clues. Candida microabscesses are not uncommon, and oftentimes when we pick it up, it's usually slightly later, and the patients may not have symptoms to begin with. And we must not dismiss the small lesions seen on radiology. Next slide. Yep, and back to you, Cherie. Thank you.
Thank you, Cherie. Please take it away.
Yeah, so we'll just come back into our case to round up. In February, as mentioned, she had a presumed CNS involvement of her chronic disseminated candidiasis. Her symptoms improved with IV liposomal amphotericin B. Her interval MRI brain in February showed reduced enhancement of the lesions in the bilateral basal ganglia. In March to May 2023, she had serial MRIs done, which showed stable lesions and no new ones. She was switched to oral isavuconazole on the 13th of March 2023.
Right. So I think we come to crunch time. It's important, of course, for her to undergo a hematopoietic stem cell transplant, but is it safe? When should we do it, and what are the considerations? So I'll ask the expert panel again, and this time I'll start with Methee.
Yes, I would say yes. So at the moment we can control the candidiasis, so it's like a golden time that we should go ahead for the transplantation. But I would continue the antifungal agent during the transplant period. But in this case, I think the patient received isavuconazole, right? But I think it's okay, but need to make sure to check the drug interaction of the isavuconazole. If not, we may have to change to liposomal amphotericin B. But I think you can go ahead for the transplant.
Monica?
Yes, I'd be having a discussion with the haematologist about how urgent the transplant is and what the best timing is for it. I would like to give the patient a few weeks of good antifungal therapy before proceeding to transplant. And I missed precisely how long of the liposomal amphotericin, but I would like to think about giving 2 to 4 weeks at least to make sure we've had a good response in the candida and continue it through the transplant. Can we use the isavuconazole through the transplant? I think we can. Maybe I'd be just more secure in using liposomal amphotericin, but then we do have to weigh up the nephrotoxicity concerns. So it's not an easy question, I think, about which antifungal to use, but I would like to make sure we've demonstrated a good response in the candida before transplant, unless it was very urgent to proceed.
Thanks, Monica. I think she had about 2 or 3 months, you know, amphotericin, ambisome, and then isavuconazole.
Oh, so good amount. Yeah.
Thuan Tong?
Yes, I think it's a difficult decision. Like Monica, we should have a conversation with the hematologist, because while we are focusing on the fungal aspects, we can try to get everything ready, meaning do we have our TDMs all ready to support this transplant, because there will be some drug interactions. Ambisome may run into troubles with renal function, so on and so forth. So I think the TDM house of side of the house needs to be considered. The other thing is a discussion with the hematologist on the kind of transplant, because are we getting a good SIP? Are we getting a haploid? Are we getting the type of transplant would have some bearing, because a MUD with ATG, we might run into a long stretch of neutropenia. The immunosuppressions will be pretty high. We do risk letting the fungal process out of control. Yeah, but like what Monica said, we would want to have as good as duration we can throw in before the transplant, and then discuss with the hematologist for the safest kind of transplant, depending on the leukemic factors and the donors involved and the kind of immunosuppression, as well as period of neutropenia. Is this someone we can do a RIC, a reduced intensity, and get things up to speed, neutrophils recovered quickly? So these are some of the considerations we should discuss with the hematologist. Over, Ban Hock.
Yeah, thanks a lot, Thuan Tong. I think we better get going and get on with the last bits of the case. Let's see what happens next. Cherie?
Thank you. So her course was slightly interrupted because she did have a COVID URTI in May this year. She was given a short course of remdesivir and recovered well. She continued to receive ponatinib and blinatumomab as a bridge to her transplant. Her disease was quite well controlled on this regime. Eventually, after complete recovery from the COVID infection, she was cleared for transplant and underwent a successful matched unrelated donor allogenic stem cell transplant on the 6th of July. She was kept on enidulafungin and isavuconazole across the transplant until she engrafted. So from August till currently, she does still intermittently have some new skin nodules after she engrafted. A repeat biopsy was done from one of the larger lesions sometime in end August, and this just showed granulomas, and again cultures were negative, and so we believe this to be part of the same immune-mediated sort of iris event, similar to prior to her transplant. So her isavuconazole is still ongoing, and she's well in the outpatient setting. These are the photos that I've actually obtained from some of the plastic surgeons who previously operated on her. I think these are from early September this year, and you can see that most of her skin lesions have settled down and no longer as dramatic and angry looking as before, although they are still palpable, and I think they will take some time to settle down. So actually we have come to the end of our case, and I think we'll open the floor for questions. I see quite a lot in the chat. Maybe I will pass the time back to the chairs.
Okay.
But how would you like to do this?
Why don't you start picking up some of the questions? First, I must thank Cherie, for presenting a great case, and the literature reviewers. And now I think we can address the questions in the chat. So Sharon, why don't you start picking some of the questions?
Sure. I would also like to thank Cherie and the literature reviewers and the expert panels for their contributions. I've enjoyed this case very much, and I think there are, broadly speaking, 3 areas. So we have can we have predicted this cause of candidiasis in this patient, and how can the immunologist, or how can a better understanding of immunology help us? Then there are the diagnostic aspects, including the radiologic aspects, and finally the treatment aspects. and whether, you know, nidulafungin was by itself would have done the trick, or could we have added something else? Could we have predicted that we would have needed an azole in the last bits of her treatment? So a lot to discuss. So I might start from the bottom and work upwards. Catherine, yes, thank you very much for your comment. And there's a question from the audience about radical excision followed by prolonged antifungal therapy based on fluconazole amphotericin to improve the prognosis of this type of patient. Not quite sure what radical excision means, but I guess it might relate to the lesions in the abdomen, perhaps, or the skin. What does the expert panel think about role of surgery in this patient? Let's talk about her skin lesions, perhaps.
Well, I think the surgery is really more relevant where you might have a single large fungal lesion and you're wanting to debulk it and you're wanting to aid antifungal penetration. But I think in this kind of immune reconstitution disease, you know, there's been a widespread dissemination, and then there is, as the immune system becomes active, these lesions tend to pop up. So it's not really amenable to surgery, I don't think.
Okay.
I think instead of surgery, sometimes we can just use a needle aspiration if the abscess is really big one. So that would help, and is a minimally invasive.
Yes.
Certainly, when there's bulky bioburden, the bulking the big lesions by aspiration might be good, but it's as Monica says, it's disseminated. It's a lot of surgery we need to do, and it's not possible, perhaps. Over.
So it might be too many lesions, and the surgery might be disfiguring and disabling in itself. So yes. Okay, so the next question to the panel is, should routine eye exams be performed at time of diagnosis of candidemia in neutropenic patients? Should this happen again once neutrophil recovery has occurred? It's a good question.
Yes.
Yes. So Methee, we'll start with you.
Yes, normally I think we recommend to do the eye exam about the second or the third week after the neutrophil has been recovered. So it's a chance that you can see the lesion in the eye. But if you do during the first week, during the neutropenic phase, so I think we should do again after the neutrophil recovery.
So are there any guidelines to help, you know, clinicians like us time the eye exam? Monica?
No, I don't think so, Sharon. I'm not aware of any. You know, there has been that debate between the American Ophthalmology Society and the ID guidelines, which say we should do it in all cases of candidemia, and the American Ophthalmology group saying we shouldn't. And there's been a recent meta-analysis by our Thai colleagues looking at the impact of ocular disease in candidemia, showing that it's actually much more prevalent than what's been previously reported. And particularly in the Asian population, Asian studies have shown up to 10%. So I think we should definitely do it. And as Dr. Methee says, it's probably best to do it once neutrophils have recovered. But there isn't a timing. There is nothing to tell us when we should actually do it.
Okay.
Okay.
I think we should do it, and plus patients can see, and any eye disturbance should prompt us to do it even earlier if need be, or repeat examination if there are new symptoms.
Okay, thank you. How about Dr. Gan? Would you like to comment as well? This was your patient, and you know, you had the control buttons from the word go, and what were your thoughts about this?
Prof. Chen, maybe I'll weigh in. I've been seeing the patient regularly.
Sure, Jasmine.
Okay.
Yeah.
Yes.
Actually,
sure.
it was
Anyone?
really hard. It was really hard to manage the patient because of drug toxicities. She actually had rising creatinine on ambisome. In terms of the triazole, she actually did not tolerate multiple classes. And there were also LFT derangements with the dasatinib and ponatinib. So it was very hard balancing all her treatment options. In addition, there were multiple cutaneous nodules. Despite adequate fungal control, as evidenced by serial PET-CT scans, going into transplant and post-transplant, there were again multiple fleshy lesions that developed. I did not think that surgical resection was an option because it was disfiguring, and there were multiple lesions and large fleshy lesions almost on many sides of her body. And what really helped was steroids, and even steroids post-transplant. There were other complications not discussed. In the post-transplant setting, she had low-level CMV reactivation. Fortunately, they did not develop into significant disease. We managed to get the CMV suppressed prior to giving her systemic steroids. And this time around, her skin lesions actually resolved without surgical resection. So actually, she's doing really well outpatient. Over to the expert panel and the chairs.
Thank you. Thank you. I think we should get on and try to address as many of the questions as possible. There's a very interesting one on what criteria were used or what criteria we can use as endpoints for evaluating the efficacy of antifungal and corticosteroid therapies, I suppose, in the setting of chronic disseminated candidiasis. Are there any other endpoints, really? Thuan Tong, would you like to take this?
Yeah, I think most would probably agree that the imaging modality would give us the best sense. Short of that, I am not aware of something that we can really be so comfortable with. Over.
Monica?
I agree. I think it's really a clinical response in our patients. I mean, sometimes the CRP can be helpful as that will be up in an inflammatory process. And, you know, in classic hepatosplenic candidiasis, where you have multiple lesions in the liver and spleen, they can be very slow to resolve radiologically. So it's not always the easiest to follow with imaging or with any other diagnostic tests. So I think it comes down to clinical response.
And Methee, a few words from you.
Yeah, I don't think there's any recommendation or guideline for the total duration of the treatment in this kind of case. And also the imaging, sometimes we will see the abscess will never go away. It's always there after several months of treatment. So I think the clinical is really important, like the both panelists mentioned. Yeah.
Okay. So I think going back to the start of the problem, there's someone asking about the diagnosis. We know that chronic disseminated candidiasis may happen without documented candidemia, and therefore it could go unrecognized. Actually, I'm not sure that it will actually go unrecognized because there are things like the alkaline phosphatase, etc., which will prompt imaging. But the question is, are there standardized clinical prediction rules or gold standard non-culture diagnostics that would help us? So a slightly more general question, maybe Methee?
I think the only non-culture or diagnostic tool at the moment available should be the beta-glucan, but the sensitivity is not that great. So I think that by the clinical, if you see the patient with neutropenia and during the recovery, he has enlargement of the liver, increased alkaline phosphatase, and positive beta-glucan that could be able to make the diagnosis. That's what I can think of.
Yes. Monica, about some non-culture-based diagnostics or clinical prediction rules, can choose either.
No, I don't know about non-culture diagnostics, but clinical prediction rules, I think it's important to remember that we don't see this very often now, this syndrome, partly because our patients are on antifungal prophylaxis. So if a patient has not been on antifungal prophylaxis and has not been able to take it, or not achieve good levels, that is when I would really have a heightened awareness for this. Having said that, of course, even in a patient on fluconazole prophylaxis, you can see disseminated candidiasis due to Candida krusei. So it's not absolute that they don't get it, but it is much rarer in patients on antifungal prophylaxis.
Thank you. Thuan Tong, you got anything to say?
No, I think the syndrome is key. Like Monica, we are not dealing with just albicans, but a whole bunch of other non-albicans, candida. And there's always the background of trichosporon if they are, say, caspofungin. So I think the syndrome, recovering patients with ALP force that's going up, the syndrome, the ALP force, are all things to think about. Over.
Oh, thank you. Someone asked about MALDI-TOF. Sharon, why don't you take that?
Thanks, Bono. So the question is the role of MALDI-TOF here for rapid diagnosis in this patient. I guess if you've got a Candida isolate, then you can rapidly ID it by MALDI-TOF, but I think to use the technique directly on a specimen, I don't think we're quite there yet. We might be there for certain bacteria, including the gram-negs, but I don't think there's much information on the rapid diagnosis of candidiasis directly from clinical specimens by MALDI-TOF. So, unless, someone on the panel or the speakers has read anything more recently.
But I think you're right, Sharon. That's not. A few more minutes. There's a question here on whether or not can a similar patient present with Candida pneumonia. Maybe I'll take that. I think that basically the general teaching is that we don't see this entity called Candida pneumonia, but the only circumstance actually is in a situation like this, chronic disseminated candidiasis. And it's actually a histologic diagnosis. So I think somewhere along in the course of this patient's disease, Cherie did show that she had these tiny nodules. And if you, luckily, well, she didn't come to an autopsy, but if you had the chance to look at the histopathology of those nodules, then you would probably be able to see what could, by pathology be passed as a Candida pneumonia. So Candida pneumonia is actually very difficult to diagnose. A positive culture from BAL, from tracheal aspirates, all these don't make the cut. And perhaps this is the only situation where you could see a Candida pneumonia, but that's not what you imagine, a simple chest X-ray with lobar consolidation. So yeah, you have to take this term Candida pneumonia and understand it carefully at a microscopic level, I think.
Hock, I had a question for anyone, really. We have new anti-Candida drugs now, some of them with a long half-life, such as rezafungin, where, this patient of Cherie's had treatment for a long, long time. Is there any role for any of these new drugs? And would you have considered it?
Maybe the various people who managed her, Jasmine or Ben Cherie.
Cherie?
Oh, it's quite a difficult question, to be honest.
my personal feeling is that, she had this fatigue from the daily commute. So I think at a time when we were not concerned about the CNS, it would be a reasonable option if it had been available at that time. Maybe, does Monica have experience with rizatriptan? I don't.
No, only in the clinical trials, not in practice. So I can't really say, Van Hock. But I agree that could have been an advantage to only having to come in once a week.
Yeah, I think according to the RESTORE study, the loss of function has been shown to be non-inferiority to the castle function in both candidemia and invasive candidiasis. So I think it can be used as well in the future, but it's a new drug, we have to see. But I think another oral drug is ibrexafungerp, that is an oral and beta-glucan inhibitor that might be more convenient in terms of administration as well.
I was just thinking of this poor lady being on IV initial for so long. I know she went on fluconazole. It's just, I guess, something to consider. And the other thought I had was maybe combination antifungal therapy. Yes, it's a pretty evidence-free zone, but this was an extremely difficult case, which I think was, had excellent management overall, and had a good outcome. That's really very encouraging.
So,
Could I?
yeah. Yes,
Sorry, could I
Jasmine.
take the chance to ask two questions? The first one is in regard to the newer agents that you talked about. I think because I was managing the CNS complications, my question to myself would be, would I have avoided the use of an echinocandin in patient with high candida burden at the start, given her progress? So that's something that I always ask myself. With this in mind, would you have done it differently? Would you have considered the once weekly agent, or even continued on anidulafungin with the benefit of hindsight? That's the first part of the question. And then the second part of the question is, what do I do with her now, given that she had 2 significant relapses of multiple cutaneous nodules? She's now immune reconstituted of immunosuppressants, and on tailing doses of steroids, her cutaneous lesions have resolved. What should the optimal duration of antifungal treatment be? Over.
I think echinocandin is not a good choice for CNS infection, even the new drug with rizatriptan. So the penetration into the central nervous system is really poor. But I was thinking, what about the flucytosine combination?
Yeah.
Because flucytosine is really good in CNS penetration. Yeah, what do you think of flucytosine?
At the point of candidemia, I think it was a little bit tricky because her chemo regimen wasn't really fixed at the end. Her disease wasn't that benign, although she ultimately had a good outcome. In the absence of transplantation, it was thought that her disease might have progressed very quickly. I did think about flucytosine at the point of initiation of embisome, but probably could have thought about it earlier. Over.
No, I mean during this time that she has the lesion in the brain. I mean, instead of using the inidulafungin and isavuconazole, what about flucytosine and isavuconazole?
I see.
I'm not sure. Yeah.
There were some difficulties with cytopenias at that point in time, so it was a little bit hard to add the flucytosine on at that point in time. Yeah.
I think it's really good that the islet has remained azole susceptible all this time. That is good news. Very encouraging.
Yeah, I would just say to Jasmine that maybe it is really difficult to use a retrospectroscope because the echinocandins are first line, and we have meta-analyses, etc., showing that survival is actually better when people start with an echinocandin. So when we are managing the patient, I think it's it's fair and proper to use and that kind of candid. What do Monica or Sharon think?
I agree with you, Ban Hock, and I agree with Jasmine. It's incredibly difficult, and we're looking at it from behind, and therefore we have more insight. But would have done exactly the same thing. Might have thought a bit about combination therapy. Might have considered 5FC if the patient could tolerate it, and if you have access to new drugs, might have considered it too. But Candida tropicalis, echinocandin. You didn't know she had CNS infection. It's it's the way to go. And my comment about the drug resistance is that we have seen quite a high incidence of tropicalis being fluconazole resistance and azole resistance. So that would not have been good in this circumstance to have taken place. So touch wood, lucky.
Okay, I think we've gone beyond 1.5 hours. We've had a good discussion. So I think we can thank all the speakers. We thanked Cherie for putting this case together, more than a year of clinical notes to review. Thank you very much, and for condensing it so well. Thank you to the people who did some literature review for us, for making those wonderful slides. And thank you to our 3 expert panelists. For those of us interested in medical mycology, we are holding ISHAM Asia in Bangkok next year. So do save the date, and hopefully we will all see each other in Bangkok.
Thank you, Ban Hock.
Yes, thanks, Sharon.
and thanks to everyone for coming. And I guess that our next AFWG ANZMIG webinar will be in February 2024. We aim to hold these 4 times a year, and we hope to put together a equally fascinating and interesting program for February next year.
Bye-bye.
Bye-bye.